session. If I can get everyone's attention, please. Thank you so much. There are, I think, a couple more seats sort of dotted here. So if you are in the back, standing, if you would like to come up and claim those seats, please do now. We have another 40 minutes, so this is your last chance before the break. Okay, well, I'm really delighted to be chairing today's session, which will be looking at the 10-year plan. How can we create an NHS fit for long lives? As I mentioned, we only have 40 minutes, but we have a fantastic panelist of speakers with us today, who will be giving very short presentations, and then we'll open the floor to Q&A from the audience. So today's session, we want to frame this session around the government's 10-year plan for the NHS and how this might allow the government to deliver a healthcare system fit for the future in the context of longer lives. I would also like to thank the Institute and faculty of Actuaries for sponsoring today's session. So without further ado, I would like to invite our first speaker to give their thoughts. So this is Nicky Draper, who will be speaking first. Following 30 years of experience in the NHS, Nicky has provided ongoing research and support to actuaries and the wider insurance industry. In 2024, she was elected as an Honorary Fellow for her service to the profession. Nicky will be setting the scene with an insight into demographics and will be touching on the importance of prevention in delivering the 10-year plan. Over to you.
Thank you very much, and I will be eschewing tradition of the day by not getting up and not having slides. So I think I want to introduce two themes really. So the first one is the demographic shift, which of course we're all well aware of, but just to set the scene. We've gained around 10 years life expectancy since the 60s, and we have a larger proportion of the population aged over 65, and that will continue to grow into the future. In fact, by 2050, that number is expected to double. And alongside that theme, we need to think about the challenges in then delivering healthcare. And for those of you who are aware, Lord Darcy delivered an incredible review of the NHS in rapid time last year, and he described the NHS in critical condition, but with strong vital signs. And what he highlighted, and what has also been highlighted by the IPPR and other bodies, is a need for a shift from hospital-based acute care to community-based care. And we're talking really along the themes of preventive strategies within healthcare, so engagement and education, and some of the more obvious ones such as screening, promotion of healthier lifestyles. Now these are core public health philosophy messages, but we feel like we've lost that core public health philosophy. And core public health philosophy is really based around action and policy that may well not have downstream effects for 10, 20, 30 or more years. And at the IFOA we have produced a couple of excellent reviews of this type of philosophy, so not 10-year plan, but maybe 20-year plan, one that's continually evolving and that we're engaged with. Increased demands on healthcare are reflected by the fact that we are seeing rising rates of some of the chronic diseases such as heart disease, diabetes, and neurodegenerative disorders such as dementia. And in fact today, Diabetes UK revealed analysis that showed that 1 in 5 of us have either pre-diabetes or diabetes, and that is set to grow. Secondly, that there are workforce and infrastructure constraints within the NHS as it currently stands. And this really brings us back to this concept of looking at long-term plans. The 10-year health plan that has been proposed looks to shift hopefully towards more community-based, away from hospital-based investment, because again, that's where we'll see greater benefits in the long term. More engagement with the digital resources, because we still have very much analog-based background in the NHS, and really away from this sickness model to one of prevention. But I really want to add some sort of positive spin on all of this, because it's easy to look at this in sort of from a doom and gloom perspective. The IFOA advocates for extended planning horizons, as I mentioned, and could well be recognised as key contributors in shaping long-term health and social care policy. This is our skill set. But from my background and perspective, long NHS background and now working in this space, preventive strategies, as we know, have a part to play. And it was modern medicine in some ways that got us to this point where we have this increase in life expectancy, but we need healthy life expectancy. So there are some interesting developments in the medical perspective, from the medical side, such things as, and these are constantly in the news, the advent of the GLP-1 agonists, the weight loss drugs. But these have a wider application. They're able to improve cardiovascular health with over and above that which might be related to weight loss. And also the second area of gerotherapeutics, where we're looking at aging as not an inevitable part in terms of our biological aging, and the whole advent of gerotherapeutics. So we know that there are approaches to increasing our life expectancy, which will increase our healthy life expectancy and move away from this increasing range within our life at the end of our lives, which is becoming ever unhealthier. So I'll just finish by saying we have two areas that we need to think about. One is this demographic shift and being able to provide more of a preventive healthcare model, and how we can tackle some of those workforce and infrastructure constraints we have within the NHS. So I'll end there and hand you over to my next speaker.
Thank you so much for your presentation to set the scene. Our next speaker is Ines Hassan. Ines Hassan is Director of Health and Economic Policy at the Ellison Institute of Technology. Ines has over 15 years of experience as a senior advisor in pharmaceuticals and global health. Before joining EIT, Ines was a senior advisor at the Tony Blair Institute. Ines will be talking about how the plan can be successfully delivered, focusing on the impact of prevention, health span, and the role of macroeconomics.
Thank you so much, Nicky, and thanks so much, Arunima, and thank you, Nicky. Actually, Nicky, a lot of the points that you've mentioned are fully aligned with the thinking we're doing at EIT. So very quickly, I just want to introduce EIT, the Ellison Institute of Technology, because you may not all be aware of it, but it's a new institute based in Oxford, which is run by Sir John Bell, and it's been funded by Larry Ellison, and we're trying to we're a for-profit organisation, and we're trying to focus on sort of research and create innovation to solve some of humanity's biggest challenges. It's very grand, ambitious goals, and a big piece of that is health and medicine and life sciences because of Sir John's background, and that's basically our goal. So if those who don't know, feel free to come and have a chat with me later. And John has been really advocating for some shifts in the UK health system for many, many years. He says 20 years. Our big focus, we really do agree, we support the government's ambitions to kind of make those three shifts that Wes spoke about so succinctly, from shift from hospital to community analog to digital, sickness to prevention. What we're trying to do at EIT is trying to see if we can help solve some of those solutions to support healthcare systems, to support the NHS, for example, in the UK. So I'm going to really quickly talk about 11 points that we think are really important in 5 minutes, so just do tell me if I run out of time. I won't go through details, and a lot of it he's actually covered superbly anyway. But just to say that prevention in particular, we think is incredibly important. The ageing population is driving all sorts of age-related diseases, and it's only going to increase. There's so many people inactive and outside of the workforce, and we've had a rise of 400,000 since the pandemic. Screening programs like Our Future Health show that actually so many people have undiagnosed issues. So a recent screening showed that 27% had high blood pressure, over half had elevated cholesterol levels, and similar issues with glucose, kidney function markers. So it's almost like a ticking time bomb. So many people will have issues, we don't have solutions for it, and it almost feels like because we're so burdened, we're kind of burying our heads in the sand a little bit. how to deliver is very difficult. I previously was working with the Tony Blair Institute, working with governments, and the idea of solving prevention always felt very overwhelming, no matter kind of what country we were working with. So we think the shift is incredibly important. Also at the Institute is Professor Andrew Scott, who many of you may know, and so he's done some great work, and he's doing even more work in this space, and some of the work we did with him last year showed that even a 20% reduction in the incidence of some of the major diseases that are keeping people out of the workforce, cardiovascular, diabetes, cancer, mental health, respiratory, musculoskeletal, could increase GDP by 0.74% within a 5-year period. So actually not even a really, really sort of long-term view, although we do want the government to have more of a shift in their thinking on that. And so actually there's a really positive news story surrounding this, and actually where you can see the NHS as a force to kind of grow the economy as well, not just as a cost sinker. And the other thing to also say that's incredibly important to us is that we think we could focus on a few modifiable risk factors for maximum impact. So there's a number of common ones like smoking, blood pressure, cholesterol, obesity, you mentioned GLP-1s. So if we do focus on those, they can have we can focus on what sort of interventions we can have, perhaps pharmacological interventions that could reduce the burden of multi-morbidity. So how can we be clever in thinking about how we target, how we get a good return of investment. And then the implementation of effective tools, I think, is very tricky. And one of the things I think is missing is we don't actually know which of the which of the interventions, including pharmacological ones, are actually the most are the most effective. Whether they're for food regulation, sugar taxes, whether it's social housing, living conditions, getting people out of poverty, all of these are important. But actually weighing up and thinking which of those are most cost effective and for which populations, I think there is still more work to be done. For John and others at our institute, we are, though, huge advocates of using medical interventions. I know that not everybody has that particular view, and so expanding access to products like the GLP-1s, some other innovative therapies like small interfering RNAs, we also think can have good impact because of that multi-morbidity effect it could have. And we think that the NHS could do so much more to make sure we can do research and try and use those drugs in a more sort of tailored and personalised way. And for example, we can use some lessons learned from the wonderful recovery trial that we ran during COVID to see what we can do to get more insights more quickly. And very quickly, I was through the other points. Just to say that we really do believe that we need to be able to leverage data and AI to be able to sort of predict the risk of disease that people are getting. And this is not my area at all, so I won't go into it in too much detail. But one thing I will say is that we are developing the idea of creating a prevention service that could support some of these particular activities, and within that service, a big part of that is thinking about how those services should really be powered by AI and data. So we can tell you more about that as well later on. The other point to make is that we really feel that you need to empower individuals with data, so they should have access to useful, accessible data and personalised tools. The other thing that in order to be able to make sure people have good access to these interventions, there may be some changes in how we approve of the regulatory approval process for some of these preventative treatments. Incentivizing patient participation is also incredibly important. And then really important to John is thinking about how to deliver preventive healthcare without burdening the current health system. And so how can we provide the service through the community, digitally enabled, easily accessible, and how does it sit alongside the wonderful work that the NHS already does. Really importantly is how do we make sure that this is not, prevention sometimes comes across as a nice to have service that's for the wealthy. And so really importantly, we know that actually the majority of some of the people who are the most deprived, they have a lot of these sort of health or age-related issues, or the diseases that are keeping people out of work are affecting them the most. And so we should be prioritising and making sure we find solutions that target them as a critical point. And the last point, I won't spend too long, is to say that we think the private sector could play a really important role as well. And so participation and collaboration with them we think is very important. Sorry.
Thank you so much. Please keep this afterwards on all the points raised. Really important. So our next speaker is Richard Maughan, Senior Director and Head of UK Policy and Public Affairs at Pfizer, bringing extensive experience from his current leadership role and previous positions at Pfizer and Eli Lilly and Company. Richard will be sharing his work as a Senior Director of UK Public Policy Affairs at Pfizer and his insights on how the NHS 10-year plan will be successfully delivered and what role vaccination and prevention might play in this.
Thank you very much, Aaron. Good morning, everyone. So I could probably save us all 5 minutes by saying I agree with pretty much everything Ines just said, but I'm going to try and build on that now a bit to that. So firstly, a bit about Pfizer. So we are a large pharmaceutical company headquartered in New York in the US. We have a really big UK footprint and a strong heritage here. We've actually been in this country for over 70 years now, almost as long as the NHS has existed. And we have significant investments in R&D here today. It's actually our 175th birthday this year as a company, which is kind of incredible. So I hope you'll take that as evidence that we certainly take a long view about some of these big questions facing society like this. So I think this is a really important moment because we're at this intersection of where longer lives meet a transforming NHS and meet a really incredible revolution in technology, as has been said. And I think there's something really exciting about that, and there's a lot of opportunity there. That said, the context is clearly really challenging at the moment in the UK. So the context for the NHS, we have, looking ahead, this exponential increase in demand. Are we going? Yeah. We're expecting exponential increase in demand. That is in large part due to an aging population. It's also in part due to us having a bigger population and due to a changing disease burden. Others have spoken a bit about, for example, the impact of obesity upon the population. It's also, we have that demand hitting up against a system which has historically underinvested in capacity. So UK hospital beds, compared to Germany, we have about a third of what Germany has per capita, have about half that of Italy and Spain. So you can see some of the challenges here. And then of course we have long-standing underlying health inequalities that exist in the UK, and colleagues have spoken previously in particular about the impact on life expectancy and healthy life expectancy and the differences that there are between the most deprived and least deprived parts of the country. So I think the challenges in the context here are pretty clear. But I think a really important reason for optimism here is innovation. And that's what I'm going to speak a little bit about now. So we really are living through what is a renaissance in human health. We have data, science, and technology coming together like never before, and that's bringing significant promise for patients. Some of the examples have been mentioned already. We have this potential of mRNA technology, for example. We have new breakthroughs in cancer research. We have precision medicine, and the list goes on. We also have the impact of AI and the potential that has within the healthcare industry is around potentially speeding up the drug development process, reaching more patients faster, and I think these are all important reasons for encouragement. I heard Nigel Edmonds, formerly of the Nuffield Trust, recently say that with respect to previous NHS plans, we maybe lacked a bit of a coherent theory of change. So my argument here is we need a theory of change which is focused on innovation adoption within the NHS over the next 10 years. And we need to get much better at that. So how can we advance an innovation agenda? Three brief points. Firstly, as has been said, we need to apply innovation to really drive this shift to prevention of ill health. I think we have a particular opportunity here around adult vaccination. I think the ILC have done some really good work here, which is super clear, for example, on the wider benefits of adult vaccination. I think they return, it's something like a 19 times return on investment to wider society, which is a pretty striking figure. We do have novel vaccine technologies in new areas coming through, which provides a lot of potential. And this is an area where we've seen the UK can lead. We saw that through the COVID-19 pandemic, of course, and we've seen it in other areas. Now we do have some challenges. We do have lagging uptake when it comes to adult vaccination across the country. If you look at the seasonal flu vaccination program, there is something like an 18% difference in uptake, again, between the best performing ICB and the lowest performing. Okay, so there's clear opportunity for improvement, and I think that's recognised in the new NHS vaccination strategy, which we very much welcome. But how can we go further on this with the 10-year health plan, really embedding life course vaccination as an opportunity for the future? So we've got a big focus on prevention. We also, as part of this innovation agenda, need to have a big focus on treating the illnesses which become more prevalent as the population ages: cancer, diabetes, cardiovascular disease, kidney disease, and other areas too. Let me just zoom in quickly on cancer. So we know that the risk of cancer, for example, is generally increases with age. We know that over 3/4 of people who are diagnosed with cancer are 60 and above. And actually, we are moving into what is, I think, a new era of cancer care. We have both incremental innovation coupled with some big breakthroughs, which I think are really important. UK cancer survival is actually at its highest level ever. Yet, as was previously said, the Darcy review has also been super, super clear that we need to get much better at bringing innovation to patients, and we need to get much better at diagnosing people earlier. And I think the National Cancer Plan this week is a good foundation for taking that forward. My final thought, okay, so I've spoken a bit about we need a plan for innovation to prevent and to treat ill health much, much better for the future. My final point is that the NHS cannot do this alone, okay? So the importance of collaboration is critical, and I'm proud to be here representing a company that's worked very closely with the NHS over the years and will do in the future. But it's also about stakeholders that sit maybe outside of the traditional health policy community here. I'm also here as a representative of a large employer with a multi-generational workforce. And I think this relationship between healthcare, health outcomes, and the economy has actually never been clearer and never been more well understood. And that provides a platform to change. I think we need more employers being active stakeholders in this debate, and it's probably people who aren't in this room here today, right? Reaching out to broader groups. And of course, for employers like mine, we all need to be thinking about how we can support and get the benefits from a multi-generational workforce. This is the first time in history that we've got 5 generations at work, and I think that's an incredible opportunity. So the vision for innovation here is really critical for the future of the NHS, and that involves actions we can take within the 10-year plan as well as outside of that, and I'll probably wrap it up.
Thank you so much for your contribution to this important discussion. So next up we have William Roberts. William Roberts is the Chief Executive of the Royal Society for Public Health. Previously, William has been a senior leader in the NHS across roles in public health, commissioning strategy, transformation, and planning. He is also a registered nurse. William will be asked to talk a little bit about the role of public health will play in successfully delivering the 10-year plan and how more care services can be moved from hospital to community settings.
Thanks very much. So if the 10-year plan is going to deliver a successful future, it's got 3 tests for me. The first thing is we've got to stop talking about long lives being a problem. Long lives aren't a problem. Long ill health is a problem. And fundamentally that's a problem of being poor and having inequality. If you look at pretty much any indicator, it's much worse if you're poor, and it's much worse if you have greater levels of inequality in your society. That really matters because if you want to think about any of the conditions that we might look at as being a challenge right now, none of them are inevitable with age. All of them could be prevented to some extent with age, which means if we were to shift from thinking about how do we treat people who are sick and people who are getting old to how do we actually make our nation more equal, firstly we see a huge drop off in pretty much every one of those conditions that we're worried about. And there's lots of ways you can do that, but you don't do that by targeting people who are wealthy, fundamentally. That's your first challenge. The second challenge is whether we're really going to think about prevention differently. So prevention's really simple. It's about stopping stuff, right? It's about stopping stuff happening. It's about stopping stuff getting worse. It's about stopping stuff spreading. So the challenge with that is, how do we reframe prevention from being something which is about 30, 40 years to something that actually makes a difference today? The reason why our hospitals can't cope this winter isn't because of something that we did 25 years ago, it's because we didn't vaccinate enough people before the winter. That is a really quick return on investment in prevention. Putting seatbelts into cars stops people dying immediately. It doesn't take 20 years, but we keep talking about prevention as if it's something that's going to take 25 years to pay back. It doesn't. Some of those things take 100 years to pay back, but many of them pay back within 1, 3, 5 years. There's a greatest hits of public health if you're interested: teenage pregnancy, HIV, road safety. I could go on. There's loads of them. All of them have something that paid back within a 12-month period of the policy being introduced. Many had a 5-year payback. Given this government has 3.5 years to go till the next electoral cycle, it probably wants to get some wind on the board because it doesn't look great in the polling right now. So if you're wanting to do something, investing in things that will actually make a difference in the next 3 to 5 years is a really big question, and therefore shifting to prevention is going to do that. As a government, you've got probably 3 or 4 levers you can pull. You've got legislation, you've got regulation, and then you've got tax and spend. And so in the plan, how do we look at the issues of creating the conditions that make it more likely to be healthy? For the first time, we've gone past 10,000 deaths attributable to alcohol in the UK. We don't have much regulation of alcohol. If you introduce minimum unit pricing, not only would you shore up the pubs in this country, which has been a big thing that the alcohol lobbies have called for, but also what you do overnight is actually reduce harm. And it's been shown in Scotland that when you introduce minimum unit pricing, people who had harmful levels of alcohol consumption reduce them significantly. So there's lots of things you can do that cost absolutely nothing financially but require you to spend political capital. And so this idea of the things that you need to do to create the conditions alongside an NHS plan is going to be critical to success. And then the third is about care into the community. So if you want to shift the care into the community, you've got to do a couple of things. Firstly, you've got to look at who's going to deliver that care in the community, and the first thing to do is actually talk to the community themselves. What was disappointing about this week's neighbourhood planning guidance was the thing in the centre of it was the hospital, not the person. And we really have to go back to saying that we build our services around the individual, not around our government structures. Secondly, you've got to think about this as being much wider than the NHS. So how do we think about the workforce that is out there that could do this tomorrow? And there are thousands and thousands of people that we spend time with every day who could change our lives. I won't ask how many people go to a hairdresser's, clearly I don't. But one of the things that you can do is you can look at how could hairdressers be part of our services in looking at things like domestic violence, looking at issues like cancer care, looking at issues like mental health support. And actually there's great work that's been done working with that group of people. They're one of 1.7 million people in the UK who would like to do more for the people that work with them to prevent health. And that could be everything from people working from a drug company all the way to people working in relatively simple jobs every day. The next bit you've got to do is really harness the voluntary sector. The voluntary sector in this country is an amazing asset, but it's on its knees, and you need to see a significant shift of money going from statutory services into the voluntary sector because they're cheaper, they're local, and on the whole they're more nimble and able to deliver, particularly in a community context. And so one of the big tests will be, what is the investment in a voluntary sector that comes alongside the investment in the NHS? I realise that there's no money, but that also seems slightly odd in a time when we had inflation for the last 150 years, as far as I can tell from any economist, and therefore there must be more money globally now than any other point in history. That's just pure maths, I believe. And therefore, where's that money gone, and how do we want to look at the tax and spend opportunities to redistribute that money into organisations that will actually be able to pay back and help your communities? Business have actually really woken up to this, is my sense. I think the business community are probably 10 to 15 years ahead of any government anywhere in the world in understanding that unless you really look after the people that live and work in your local area, you're not going to be able to have a healthy, sustainable workforce. Because even with growing technology, we know that we're not going to see the opportunities for everybody to not have any work. And then once we don't all have any work, what are we going to do every day to keep us happy? So if we're not working, you've got to pay for universal basic income. So there's a real challenge for businesses, and they really get that. And then finally, you've got to invest in local infrastructure. So if you're going to do all of this, this also requires you to have around you a whole range of things that make it happen. And if you're lucky enough to live in London, you're probably further than 15 minutes from a major trauma centre with some of the world's most amazing doctors, nurses, sterilists, etc. If you live in bits of Cumbria, if you live in bits of Cornwall, you might be 5 hours away from your nearest hospital. So what's the infrastructure you need to build around that to enable local care to happen? Because as somebody who's worked in both rural, coastal and urban areas, I can tell you it's really different what I used to take to work in each of those 3 jobs. So that challenge of, let's not talk about old age as a problem, let's talk about it actually as an amazing future, but let's start thinking about how we reinvest in equality in this country. Secondly, let's really shift to an investment in prevention in the short, medium and long term rather than it being a huge issue. And then finally, let's really think about how we put services into the community by investing in something that's not just the NHS. Thank you.
We only have a few more minutes, and I'm really keen to get all of the speakers in, and hopefully 1 or 2 very quick questions. So Jonathan Rallings, Senior Policy Advisor at the County Councils Network, has 25 years of experience in the public and voluntary sectors, including the NSPCC, London Councils, and Barnard, where he served as head of policy. So Jonathan will talk a little bit about the role of local government and how it can successfully deliver the 10-year plan.
Thank you. So I'm going to come at it obviously more from a social care perspective, which is what our members deliver. And for those of you who aren't aware of who the County Councils Network are, we're a substrata of the Local Government Association that have 37 specifically county-based members. So as you can imagine, the issues around the demographics that are raised earlier are even more pertinent to our members because we know that we have the older demographics. We also know that we have most of our members are in those rural and coastal areas that you're talking about where sometimes access to healthcare can be poorer. Now, I mean, a 10-year plan for the NHS is really important. From a social care perspective, I think, our members are agreed. It offers a really valuable opportunity to build on everything that we've been doing over the past decade towards better fusing health and care services. But whilst there's been lots of progress made, the development of ICSs, which have brought together on a sort of a 42 footprints across the country, health and social care working in closer collaboration, but even the departmental name change that we now have, the Department of Health and Social Care, is important. And so there's a lot of anticipation before the election that this would be the period, sort of parliament where we might actually really push us over the edge. And unfortunately we have been somewhat disappointed because a 10-year plan for health has not been accompanied by a 10-year plan for social care, which does feel like a massive omission. And we've got, obviously brilliant that we've got Louise Casey on board. If there's anybody I think our members would want to actually be running a review of this sort, it would be Louise Casey. But the reality is, what is she actually going to say that's going to be any different from what we've already discovered over the past 10, 20 years? We have produced our own reports, LGA, and then obviously there are the very big reforms, all sorts. We know what it's going to say, and we also know what the sticking point is, and the sticking point is how you pay for it. But we're getting past the point where that is the number one question for local authorities about who pays. It's actually, we have to make sure that our services are shored up now, because this demographic time bomb is continuing to go forward and is continuing to tick. And I think the 3 shifts that have been announced are absolutely where our members want things to be. They're absolutely what we want to contribute to. But we need actually a little bit of recognition that social care, local authorities are the Cinderella service here. And so for those of you in the audience who are more from a NHS background and a health-based background, I think I've got 3 key things that I want to embed in your head about where your local authority colleagues may be on all of this agenda at the moment, and things to consider as we try and fuse, because we know that the 10-year plan is brilliant and we want to move it forward and help move it forward, but there are a few challenges. First, I think very strongly I hear from our directors of adult social care in particular and others, and our children's as well, because I work across both. There's a real wish, please don't over-medicalise things too much. And there is a temptation. The ICS model, it's still not quite as balanced as it could be at the moment. We did the first local authority-based study into this a couple of years ago. We looked around. I think the best quote I got was, if you've seen one ICS, you've just seen one ICS because all 42 are so dramatically different. And there are some absolutely brilliant pockets of work, but there are some more difficult areas. And that matters particularly when you've got sort of different models that local authorities are trying to engage with. You've got a situation like in the northeast where you might have 13 or what have you, different authorities trying to actually influence ICB decision making. And then you've got somewhere like Essex, which is currently having to work across 3 separate ICSs. There is no way Essex has the ability and the resources to actually be able to meet all of the demands and to provide a cohesive pattern for Essex in the way that it might be in other areas of the place. But there's also on the medicalising stuff, something really important to think about prevention. I say this having also, as my bio says, worked in the children's sector an awful lot. There is a temptation from governments, particularly the Treasury, give us the numbers, give us the figures, give us the return on the investment. Now obviously, as William's already said, some of this is very easy to do, some of this is much, much longer. But in particular, when you are dealing with care, it is not as simple as when you're dealing with sort of injecting somebody with a drug. You cannot manualise what you're actually doing as a carer that creates that magic in quite the same way. And it's really tempting for Treasury, it's really tempting for ICS to just go, no, let's just go for the thing that gets us the easy numbers, because then we can do it. But it may well not be the most effective thing, and I would urge all commissioners working across to think about that. Secondly, I really hope that there will be more of a united front, and we've talked a lot about it's not just about processes, it's also about culture. There's 2 really important differences between the NHS and local authorities that have come out in the wash for us. One is direct democracy. We deal with the politics, and I'll come on to something a little bit more about that in my 3rd point. And that is more challenging, I think, for some of our colleagues in the NHS as we've got to work closer, that they have to realise what we're trying to balance there. The other thing is we have to keep a balanced budget by law. So you probably, I know local government is not the most exciting, even a day after probably the most significant announcement of local government for 50 years, it still didn't really get a huge lot of coverage because most people really don't find it that interesting. But you've probably heard Section 114s out there, etc. Local authorities effectively going bankrupt. That is because they have to keep this balanced budget. So when your local authority is saying, we are really nervous about doing that, it's because of that element of the culture, and it's because of the pressure of the members. But I think the other thing I really want to highlight is yesterday's announcement. Local government reorganisation and devolution is going ahead. It is, there's been, we've said at County Councils Network, it's almost been a bit like death by 1,000 cuts over the past sort of 20 years as they have gradually tried to move away from a 2-tier model with our members and to actually embed more of a devolved agenda across England. This is going to really accelerate under this government. It's really clear there's going to be an awful lot of change for our members. That's going to create an awful lot of political friction, misdirection, all sorts of different things that are going to be preoccupying local authorities in the area. But it also is going to create challenges that we want others to be aware of and to engage with. And in particular, when we're deciding how we're actually going to organise new geographies within local government, a lot of that is very much still up for grabs at the moment. Now, there could be, as an example, a Hertfordshire or what have you. Do you actually put that new local authority on the same footprint as the old Hertfordshire that people know where they're working, or do you split it in 2? In which case, how do you disaggregate that? Which part goes there? We already went through the process when ICSs were being set up of the issues around coterminous boundaries, making it easy to work with, etc. So what I would urge is if anybody is sitting in an ICS and says, I really like that geography, that really works and it means we can deliver services better. Or, actually I can see a way that if the local authority was organised like this and we cut this bit out, it would actually fit so much better for delivery of social care services. Your voice is important. Social care represents about 70% of what local authorities deliver, and even beyond the adult social care that's important here, there's obviously huge amounts of interaction between health and local authorities when it comes to children's social care, special educational needs, etc. So actually keep an eye on where the geographies may be changing in your area, and feel free to actually wade into those debates and try and shift them, because the better we can get those geographies working, the better we're going to be able to actually deliver. Because there are opportunities, and obviously local authorities stand here ready to try and create a much fitter, healthier, ageing society going forward.
Sorry to have to cut this session short. We won't be able to go to the Q&A, but please do